Welcome to EMDR, the science behind the therapy, a podcast from the Sonoma Psychotherapy Training Institute. I'm your host, Dr. Andrew Leeds. In each episode, we explore the latest research and clinical insights about EMDR therapy, highlighting the leading scholars' latest contributions to EMDR research, education, and training. Whether you're a therapist, a student, or a lifelong learner, I'm here to connect you to the science behind the practice of this remarkable form of psychotherapy. I welcome your feedback and suggestions for topics to be considered or any issues you encounter in my summaries of the research. You can reach me through the Contact Me form on any of the websites listed in the show notes. Before we start, I want to draw your attention to the unique EMDR therapy training delivered by Sonoma Psychotherapy Training Institute. Sonoma PTI provides a comprehensive program in 4 two-day modules spread over a 12-week period. These 4 modules include all required hours of lecture, practice, and group consultation. Our Zoom-based program is open to clinicians from throughout the United States, Canada, and Europe. I invite you to look over our curriculum and training schedule at sonomapti.com. In today's podcast, there are 20 new studies to explore. So to cover them all, some will get the typical in-depth coverage, and some will receive an abbreviated summary. Keep in mind that nearly all these studies are open access and are listed with direct links to their publishers' websites in the August 2026 blog listing of references. We will open with 3 qualitative studies, a less common and challenging form of research, which often yields important insights. The first of these 3 qualitative studies is a German study that investigated how clinicians determine set duration during reprocessing. Then, an Italian report on the legal admissibility of courtroom testimony by children and teens after EMDR therapy, and finally a report from Danielle Decker in Oakland, California, a discussion of the full impact of successful reprocessing beyond symptom resolution on patients' sense of self and their worldview. Then we consider a randomized controlled trial delivered by graduate students in China comparing EMDR with imagery rescripting for trauma resolution. Then there are 3 meta-analyses. The first, a massive analysis of 55 studies of non-pharmacological interventions for trauma. The second examines dropout rates in various forms of manualized treatment for trauma. And the third explores treatment effectiveness with disaster survivors. Then we will return to the role of fidelity rating with an international study on the use of the DePrend EMDR protocol for major depressive disorder in a low-resource Pakistani setting. Next, we will explore a series of 10 review articles covering a wide range of research designs and topics. Then in 2 brief reports, we will consider a feasibility study of EMDR for teens with anorexia and a clinical instruction article on working with non-binary and transgender EMDR clients. We will close the episode with a summary of a major critique of the 2025 American Psychological Association Clinical Practice Guideline for PTSD in adults, written by Chris Lee, Adu Young, Derek Farrell, Larissa Meisner, Sarah Dominguez, and Sharif Halefi in the Journal of EMDR Practice and Research. Remember to access any of the original research papers mentioned in the podcast. You will find a complete list of references and links to each of these studies in the August 2026 blog on sonomapti.com. A link to these references can be found in the show notes. You can also just go to sonomapti.com, click on the blog section on the far right of the menu bar, and then select the August 2026 listings. So let's get started with today's episode from Qualitative Insights to Meta-Analyses, EMDR Therapy at the Frontiers of Trauma Research. We begin with 3 qualitative studies, a less common and demanding research approach that often yields deeply nuanced clinical insights. During the reprocessing phases of EMDR therapy, clinicians have to decide how long to make each set of bilateral stimulation, whether using eye movements, taps, or tones. Do they follow a set number of passes or rely on careful observation of nonverbal changes? This is the question explored by PAP and co-authors in a preprint released in early 2026. This was a survey-based pilot study with German-speaking clinicians certified in EMDR therapy. Participants completed a 2-part questionnaire on how they used the EMDR standard protocol and how much they relied on nonverbal changes during trauma processing in everyday practice. The survey gathered information on interruption strategies for sets of bilateral stimulation, ratings of how often various minimal nonverbal changes occurred, and how strongly these changes signaled shifts in emotional valence. They collected key therapist, patient, and setting characteristics such as age, gender, therapeutic orientation, training, and inpatient versus outpatient work. PAP and co-authors recorded which criteria therapists used to decide how long to run bilateral stimulation sets, what they thought happened if they stopped too early or too late, how often and how strongly they relied on minimal nonverbal changes, and how open they were to using biofeedback tools. They collated ratings of the perceived usefulness of specific nonverbal cues in face, breathing, posture, gestures, autonomic signs, and vocalizations. The main results showed only a small group relied solely on counting a fixed number of bilateral stimulation. Most set lengths were based on minimal nonverbal changes alone or combined with counting based on facial relaxation, forehead relaxation, smiling, deeper inhalation and exhalation, and other breathing changes seen as signs of valence shifts. PAP and co-authors found that with younger, behaviorally focused inpatient therapists, they tended to favor counting down, and older, psychoanalytically oriented female therapists more often relied on nonverbal changes. Therapists generally agreed that missing the best moment to stop stimulation was problematic, but many felt hesitant about using objective biofeedback tools as measures of change. PAP and co-authors noted key limitations, including reliance on self-report from German-speaking EMDR therapy clinicians, use of an exploratory, non-validated questionnaire with limited answer options, and lack of observational or outcome data. They concluded that EMDR therapy appears to rely on informal, poorly described use of minimal nonverbal changes. They suggested these issues should be explored with experimental AI and biofeedback-supported research to better understand these factors and improve interruption criteria. EMDR-trained clinicians sometimes have concerns about whether or not to offer treatment to children and teens before they are scheduled to give courtroom testimony. There have been questions about the admissibility of testimony because EMDR therapy has distinctive effects on the vividness of sensory memories and the coherence of the narrative. To explore this question, Pecoroni and co-authors conducted a qualitative jurisprudential case series analysis of Italian Supreme Court decisions to examine how EMDR therapy influenced judicial assessment of testimony reliability in criminal cases involving minors. The design relied on targeted retrieval of final, non-appealable Supreme Court rulings from the juror legal database up to January 2026 using predefined search strings and inclusion criteria, followed by independent screening and interpretive analysis of judicial reasoning. They extracted decision references, procedural context, the procedural role attributed to EMDR therapy, the court's reasoning about testimony credibility and memory reliability, and case outcomes. Then they analyzed recurrent themes across 5 eligible decisions. The decisions consistently treated EMDR therapy as a clinically legitimate trauma intervention for PTSD. The analysis concluded that the Supreme Court required concrete, case-specific evidence of memory distortion before questioning testimony, instead of assuming that EMDR therapy inherently created false memories or reduced credibility. Pacchioni and co-authors found that EMDR therapy was usually raised by defense counsel as a potential source of memory alteration, but that the Supreme Court rejected abstract claims of unreliability. Instead, the Italian Supreme Court focused criticism on methodological shortcomings, such as suggestive practices, inadequate clinical documentation, and role confusion between therapist and forensic evaluator. The Supreme Court applied strict standards of scientific causation when psychological harm was alleged. Secondary findings indicated that the court adopted a cautious, context-sensitive, case-by-case model of testimonial evaluation aligned with contemporary memory research and international forensic recommendations rather than treating therapy-derived memories as automatically suspect. Pacchioni and co-authors acknowledged several limitations, including the small set of 5 decisions, restrictive eligibility criteria, reliance on a single legal database, and the exploratory nature of the analysis, all of which constrained generalizability beyond the identified rulings. The main finding was that EMDR therapy did not emerge as an automatic weakening factor for testimonial credibility. Instead, its forensic relevance depended on rigorously documented clinical procedures, clear differentiation of therapeutic and investigative roles, and careful reconstruction of how memories were formed and transformed in each individual case. Most of the research published on EMDR therapy assesses its effects using standardized psychological tests of symptoms. However, clinicians and their clients often observe that EMDR therapy can produce profound changes that are not captured with objective measures. To expand the literature on the nature of EMDR therapy's impact, Danielle Decker conducted a qualitative phenomenological study using Georgi's descriptive method. She carried out in-depth Zoom-based interviews with 8 adult clients in U.S. outpatient settings who had experienced an adaptive resolution in EMDR therapy in the previous 6 months. Subjects were recruited from therapists trained through the EMDR Institute for Creative Mindfulness and screened with a working definition of adaptive resolution. Decker used semi-structured interviews, verbatim transcription, and stepwise phenomenological analysis to derive meaning units, psychological transformations, and a general experiential structure. She included standard EMDR indicators, such as subjective units of disturbance ratings, validity of cognition ratings, and body scan reports. But her primary focus was on clients' narrative, embodied, and temporal descriptions of change rather than symptom scales. She found that adaptive resolution was a dynamic process of movement from pre-therapy constriction through opening and widening into expansion. This process included a descent into traumatic material and a reemergence with a revised narrative, increased peace, and an expanded sense of self, relationships, and world, often involving spiritual or transpersonal growth, altered states of consciousness, and an expanded worldview. Decker noted her sample was small, largely white, and relied on therapist-judged resolution. Decker concluded that adaptive resolution in EMDR therapy was a multidimensional change process extending beyond symptom reduction to existential, spiritual, and relational transformation, and suggested that research and training should more fully incorporate clients' lived experience and transpersonal dimensions when conceptualizing trauma resolution. Next, we turn to an unusual randomized controlled trial carried out in China with graduate students with brief training in a manualized form of EMD and imagery rescripting. Fan and co-authors carried out a 3-arm randomized controlled trial with a mixed methods design to test a 4-session peer-delivered protocol integrating an intervention similar to eye movement desensitization together with imagery rescripting against standalone imagery rescripting and a care-as-usual psychoeducational condition in 95 Chinese university students with moderate trauma-related distress. These students were treated by 5 senior students with psychiatric or applied psychology backgrounds who were recruited as therapists and who underwent 20 hours of manualized training in EMD and imagery rescripting. Primary outcomes were depression, anxiety, self-efficacy, and resilience, assessed at baseline, post-treatment, and 1-month follow-up, with trauma memory vividness, emotional arousal, and negative beliefs as process measures. They also conducted qualitative interviews with a subsample of participants and peer therapists to explore mechanisms and feasibility. They found that both active conditions produced marked reductions in depression and anxiety and increases in self-efficacy and resilience compared with care as usual. However, effects on self-efficacy were not statistically significant. The combined EMD therapy plus imagery rescripting condition showed particularly stable maintenance of resilience gains at 1 month. In contrast, resilience declined significantly after standalone imagery rescripting. Analyses suggested that resilience improvement was linked to simultaneously increases in traumatic memory vividness, emotional arousal, and negative beliefs. They additionally reported that qualitative data indicated that the eye movement component created a sensory affective buffer that reduced emotional flooding and made subsequent rescripting more tolerable, while the egalitarian peer identity reduced hierarchical stigma and facilitated disclosure. Peer therapists described the manualized stepwise protocol and multi-layered supervision and screening as providing a manageable safety net that supported delivery without overwhelming vicarious distress. The authors noted several limitations, including a highly educated sample with moderate, not severe PTSD, a short 1-month follow-up, and reliance on self-report mechanisms without physiological corroboration. They noted that the minimally trained lay peers who lacked supervised clinical experience inevitably would deliver service inferior to that of senior qualified professionals. They noted that the absence of an EMDR therapy-only arm. They concluded that a brief, peer-delivered, culturally adapted EMD therapy plus imagery rescripting protocol represented a feasible, scalable way to reduce distress and bolster resilience among traumatized Chinese students. They concluded that the use of EMD that integrated sensory and cognitive work supported more durable psychological change than imagery rescripting alone. Next, we turn to an interesting series of meta-analyses that reveal essential information about dropout rates in treatment of PTSD, the effectiveness of non-pharmacological treatments for PTSD, and of post-disaster interventions in a variety of regions and types of disaster. Wall and co-authors conducted a systematic review of 55 randomized controlled trials and meta-analyses published between 2008 and 2025, which compared non-pharmacological interventions with control conditions, pharmacological treatments, or other therapies in adults with PTSD across diverse trauma exposures and clinical settings. They searched 12 major databases and trial registries up to January 2025. They included English language, randomized controlled trials, systematic reviews, meta-analyses, and prospective trials for a wide range of interventions, including mindfulness-based stress reduction, cognitive behavioral therapy, EMDR therapy, laughter therapy, acupuncture, yoga and meditation, and diet and lifestyle changes. They found that mindfulness-based stress reduction and cognitive behavioral therapy consistently and substantially reduced PTSD symptom severity, while some trials reporting improvements of up to 45% in core PTSD symptoms, anxiety, and depression. EMDR therapy showed robust efficacy across several populations, often matching or surpassing cognitive behavioral therapy for PTSD symptom reduction and anxiety reduction, and appeared particularly useful when verbal recounting of trauma was limited or difficult. Laughter therapy, acupuncture, and yoga-based interventions generally improve stress regulation, mood, sleep quality, and functional outcomes, while diet and lifestyle modifications, including flavonoid-rich diets, structured exercise, and sleep-promoting routines, showed only tentative benefits for mental health and sleep. Their findings highlighted the role of neurobiological and endocrine mechanisms in PTSD, including dysregulation of the hypothalamic pituitary adrenal axis, inflammatory markers, and neurotransmitter systems, and suggested that some non-pharmacological interventions may partially normalize these pathways, something that many studies have found true of EMDR therapy. They found non-pharmacological approaches were generally well-tolerated, had few reported adverse effects, and often enhanced patients' sense of control, resilience, and engagement in treatment. Limitations included substantial heterogeneity in designs, intervention protocols, populations, and outcome measures. Many trials had small sample sizes, high or unclear risk of bias, and short follow-up periods. They concluded that non-pharmacological interventions offered promising complementary or standalone strategies for reducing core PTSD symptoms, particularly for individuals who are unwilling or unable to use pharmacotherapy. They suggested that mindfulness-based stress reduction and cognitive behavioral therapy currently had the strongest evidence base, and that EMDR therapy was a powerful option when trauma-focused processing without extensive verbalization was needed. One of the essential issues in manualized treatments is the associated dropout rates. Pennick Smith and co-authors conducted a secondary meta-analysis in 2025 that used random effects models to estimate psychotherapy dropout across 232 manualized PTSD treatment protocols delivered to 124,000 U.S. service members and veterans. They found an overall dropout rate of 25.6%. Dropout was defined as the percentage of clients who began a protocol and terminated prematurely. They measured weighted dropout for various weekly outpatient trauma-focused protocols. They found dropout rates of 40.1% for cognitive processing therapy, 37.2% for virtual reality exposure therapy, 34.7% for prolonged exposure therapy, 19.8% for written exposure therapy, and 13.6% for EMDR therapy. For the non-trauma-focused weekly interventions, they found dropout rates of 39.9% for acceptance and commitment therapy, 20.9% for behavioral activation and therapeutic exposure, 23.6% for seeking safety, 28.8% for protocols emphasizing emotion regulation and interpersonal skills, 31.6% for mixed cognitive behavioral protocols, and 30.6% for psychoeducation. Thus, EMDR therapy had the lowest dropout rate at 13.6% of any of the weekly outpatient trauma-focused protocols. For some other non-trauma-focused methods, they found dropout rates of 20% for mindfulness-based stress reduction, 16.8% for transcendental meditation, 10.3% for a mantra repetition program, and 25.2% for other mindfulness-based protocols. Intensive outpatient programs overall showed 7.9% dropout, including 8.5% for cognitive processing therapy, 5.5% for prolonged exposure therapy, and 16.9% for other intensive outpatient programs. Limitations included incomplete capture of all relevant studies, lack of data on which specific treatment components drove dropout, unknown fidelity in effectiveness studies, small numbers for some protocols such as group-based exposure therapy, and a focus on dropout rather than symptom change or functioning. In their main conclusions, Pennick, Smith, and co-authors found that protocol choice mattered, with weekly individual trauma-focused formats such as cognitive processing therapy, prolonged exposure therapy, and virtual reality exposure therapy showing comparatively high dropout, whereas present-centered therapy, mindfulness-based stress reduction, mantra repetition program, group-based exposure therapy, and intensive outpatient programs offered substantially lower dropout benchmarks. It should be noted that Pennick, Smith, and co-authors did not concurrently compare treatment effectiveness on symptom reduction with dropout rates. Nevertheless, they suggested that expanding access to lower dropout options such as EMDR therapy and to intensive outpatient delivery alongside structured dropout prevention strategies could improve psychotherapy engagement in military PTSD care. Semerci Uzun from Gümüşhane University in Turkey conducted a systematic review and meta-analysis that synthesized post-disaster psychotherapeutic intervention trials. They carried out comprehensive searches of major international databases in 2022, including randomized controlled and quasi-experimental studies with disaster-exposed populations. They included 27 studies with a total sample of over 6,000 participants from 12 countries worldwide. They assessed methodological quality and calculated standardized mean differences in confidence intervals with a random effects model due to high heterogeneity. They examined outcomes on PTSD, depression, anxiety, and quality of life. They evaluated moderators, including country or continent, type of disaster, type of psychotherapeutic intervention, and types of measurement tools. They found post-disaster psychotherapeutic interventions had a large overall effect on reducing symptoms. Methods they identified as effective in the post-disaster period included EMDR therapy, cognitive behavioral therapy, and exposure-based methods, as well as some other modalities such as acupuncture and yoga. They noted limitations including small sample sizes in some trials, lack of blinding, reliance on pre-post test designs, and substantial between-study heterogeneity. They emphasized that the diversity of measures and interventions and the limited number of studies for some modalities and disastrous types constrained the ability to draw firm conclusions about differential effectiveness across all contexts. Semerci and Uzun concluded that post-disaster psychotherapeutic interventions overall had a positive and substantial impact on mental health, especially on PTSD symptoms. They found that EMDR therapy, cognitive behavioral therapy, and exposure methods appeared particularly beneficial after earthquakes. They suggested future research should use higher quality designs, carefully selected and consistent measurement tools to inform evidence-based disaster response planning. The EMDR-trained protocol has been widely researched in a variety of randomized controlled trials in well-resourced countries in Europe as a treatment for major depressive disorder. Kahn and co-authors employed an exploratory, sequential, mixed methods design to assess treatment fidelity for an adapted EMDR-trained EMDR therapy protocol delivered to patients with major depressive disorder and clinically significant depression-related disability in a low-resource Pakistani setting. This research was funded by King Solomon Center for Disability Research and the EMDR Research Foundation. Qualitative data came from Delphi interviews with 3 independent EMDR therapy experts who reviewed recordings of 14 sessions from 4 randomly selected cases. The quantitative data came from expert-completed EMDR fidelity rating scale scores and therapist-completed EMDR competence scale questionnaires. The authors used the EMDR fidelity rating scale to rate adherence across all 8 phases of the adapted EMDR-trained EMDR therapy protocol and the EMDR competence scale to capture therapists' self-reported experience, accreditation status, and professional development in EMDR therapy. The authors found that therapists delivered the adapted EMDR-trained EMDR therapy protocol with high process fidelity characterized by principled adaptability, integrating culturally responsive language, religiously congruent metaphors, and contextually sensitive pacing while preserving the core procedural elements across all protocol phases. Quantitatively, expert raters scored adherence as acceptable to very good in every phase, with the highest mean scores for history-taking, treatment planning, and installation, slightly lower but still strong scores for body scan and closure, with substantial inter-rater reliability. They identified barriers to fidelity such as patient stigma, low mental health literacy, overlapping somatic and anxiety presentations, high therapist caseloads, time constraints that occasionally led to compressed sessions or omission of less central elements, and reliance on Western-developed fidelity instruments that had not yet been culturally adapted or psychometrically validated for South Asian settings. The limited number of therapists and recorded cases and restriction to a single country and setting further constrained generalizability and the ability to model the dose-response relationship between fidelity and clinical improvement in depression-related disability. The authors concluded that the adapted EMDR-trained EMDR therapy protocol could be implemented in Pakistan with strong process fidelity that balanced clinical rigor with cultural and religious resonance, supporting feasibility for scaling as a depression disability intervention in a low-resource context. They emphasized that sustaining high process fidelity functioned as both a clinical and ethical imperative. They recommended future multi-site studies that culturally adapt and validate fidelity measures and link fidelity indices to symptomatic outcomes and cost effectiveness. Next, we will examine concise summaries of 10 review articles that reference EMDR therapy. The first of these was published by An and colleagues who systematically reviewed 6 quantitative studies from 2014 to 2024 evaluating psychosocial interventions for PTSD and complex PTSD in youth and adults exposed to interpersonal trauma. Across ages, several methods, including trauma-focused CBT, intensive prolonged exposure, online mindfulness-based interventions, STARE, and EMDR therapy, reduced PTSD and complex PTSD symptoms. EMDR therapy reduced PTSD and complex PTSD symptoms comparably with CBT methods, improving both core PTSD features and disturbances in self-organization when delivered with structured, evidence-based protocols, underscoring its role alongside CBT and exposure-based approaches as a key modality within the complex PTSD treatment landscape. The authors noted that the small number of heterogeneous studies and limited cultural diversity constrain conclusions about comparative efficacy and generalizability. Next, we consider the treatment of tinnitus. Arsenal et al. Conducted a scoping review of 30 studies from 2014 to 2025, examining links between tinnitus and psychiatric comorbidities. Tinnitus, or tinnitus, frequently co-occurred with anxiety, depression, stress, insomnia, somatization, and occasionally psychosis. Greater resilience, self-esteem, and social support were associated with reduced distress. Tinnitus-focused interventions, including CBT, CBT for insomnia, mindfulness-based cognitive therapy, tinnitus retraining therapy, EMDR combined with CBT, and cochlear implantation, all generally reduced tinnitus distress and often improved mood and sleep. EMDR, particularly when integrated with CBT and tinnitus retraining therapy, emerged as a promising trauma-focused approach targeting the neuropsychiatric dimension of tinnitus. The authors highlighted methodological heterogeneity that limited causal inference and called for longitudinal, multidisciplinary research to clarify mechanisms within auditory and non-auditory networks. Next, we return to data on treatment of children and adolescents, which tends to be less commonly studied than treatment of adults, as we discussed in episode 11 of the podcast. Dahlgren and colleagues published a 2026 mapping review of 116 systematic reviews covering 200 treatment comparisons for children and adolescents with a broad range of mental health diagnoses. About half of the interventions were psychological, over one-third pharmacological or nutritional, and the remainder combined approaches, with follow-up predominantly short-term and long-term data rare. Overall certainty of evidence was generally low or very low, although cognitive behavioral therapy, CBT, showed moderate to large effects versus treatment as usual for anxiety, depression, ADHD, and obsessive-compulsive disorder. EMDR therapy, along with trauma-focused CBT, dialectical behavioral therapy, physical activity, and mindfulness-based interventions, demonstrated potentially useful benefits, but most findings rested on uncertain evidence and limited follow-up. EMDR therapy's role appears promising within trauma and PTSD care, yet remains comparably constrained by the same methodological limitations affecting other modalities, underscoring the need for more robust, long-term trials to clarify its relative effectiveness. Jabril and colleagues conducted a 2026 systematic review of randomized and quasi-experimental studies evaluating psychological interventions for PTSD and first responders, including EMS personnel, police, firefighters, disaster workers, and other emergency services. Trauma-focused interventions, particularly EMDR therapy and cognitive behavioral therapy with exposure, showed the most consistent reductions in PTSD symptoms, and in some cases, improvements in work resumption and comorbid conditions, underscoring EMDR's central role among evidence-based treatments. Other individually delivered approaches, such as brief eclectic psychotherapy, narrative exposure therapy, expressive writing, eclectic group counseling, and stress resilience training, yielded beneficial but generally less robust or durable effects. Group-based interventions, including critical incident stress rebriefing, resilience training, and mindfulness programs, produced mixed findings, with some short-term gains but also some transiently adverse outcomes. Overall, the review found moderate evidence for EMDR and CBT, but low to very low certainty for group-based resilience and mindfulness-based strategies, highlighting the need for EMS-specific, high-quality trials with standardized outcomes and extended follow-up. Lethner and colleagues conducted a meta-analysis of 73 randomized trials with about 5,700 participants to examine how dosage and intensity influence outcomes and completion in individually delivered, guideline-recommended trauma-focused treatments for adult PTSD. Methods included prolonged exposure, cognitive processing therapy, cognitive therapy, EMDR therapy, narrative exposure therapy, and trauma-focused CBT. Across methods, including EMDR therapy, they observed medium to large effects on PTSD and depression at post-treatment and sustained medium PTSD effects at follow-up, with larger effects compared to inactive and small but significant effects versus active comparators. Their results indicated that EMDR therapy performs within the high efficacy range of leading trauma-focused interventions rather than standing apart as an outlier. High-intensity formats, those with around 270 minutes per week, produced higher completion rates, and flexible need-based dosing yielded stronger PTSD effects than fixed-dose protocols. More sessions did not consistently predict better outcomes, particularly for depression, underscoring that personalization and intensive engagement-enhancing formats may be more critical than simply increasing total dose. Nolan Bowes and colleagues conducted a 2026 systematic review of 23 studies from 2004 to 2024 on trauma-focused treatments for PTSD in refugee and asylum-seeking minors aged 4 to 21 years living under uncertain residence status. Most participants were boys from Afghanistan, Syria, Iraq, Eritrea, Somalia, and Central American countries, treated in outpatient clinics, child welfare and school settings, residential care, and community services. PTSD symptoms were assessed using standardized measures. Across studies, cognitive behavioral therapy, narrative exposure therapy, EMDR therapy, both administered alone or combined with trauma-focused CBT or play-based interventions, and some other trauma-focused modalities, such as expressive arts and multifamily groups, produced significant PTSD symptom reductions in most trials with a median effect size of 0.97 and no adverse effects. EMDR therapy emerged as one of the 3 most consistently effective approaches with outcomes comparable to CBT and narrative exposure therapy and with evidence of gains maintained in about 1/4 of studies. The result of this meta-analysis challenges the assumption that stable residence is necessary before offering trauma-focused therapy to refugees and asylum-seeking minors. Niemeyer and colleagues conducted a 2025 German systematic review of randomized controlled trials testing exercise as an adjunct to psychotherapy for adults with PTSD. They identified 5 trials with 677 participants. Exercise-augmented treatments were compared with psychotherapy alone, treatment as usual, or other active controls, with PTSD symptom severity as the primary outcome and depression, anxiety, and exercise behavior as secondary outcomes. 3 trials demonstrated medium to large effects favoring exercise-augmented psychotherapy, particularly when moderate to vigorous aerobic exercise, alone or with resistance training, was integrated weekly over 9 to 12 weeks, with 90-minute individual trauma-focused sessions such as EMDR, prolonged exposure, or cognitive processing therapy. EMDR-based combinations showed benefits comparable to other trauma-focused modalities, suggesting that the added value of exercise may be modality-independent, yet compatible with EMDR's rapid reprocessing. Across studies, effects on depression and anxiety were inconsistent. No treatment-related adverse events were reported, and risk of bias was generally acceptable, though small sample sizes, protocol heterogeneity, and limited diversity highlight the need for more rigorous, trauma-informed trials. Rajeswaran and colleagues conducted a 2026 scoping review using a narrative synthesis framework to examine EMDR therapy for parents of children from birth to 12 years. 11 empirical studies, mainly clinical case reports, and small pre-post trials, evaluated EMDR delivered individually or in groups to parents, often alongside other interventions such as psychoeducation, parent training, or supportive counseling. EMDR therapy was consistently associated with reductions in parental PTSD, depression, and anxiety, and with gains in parental self-acceptance, self-efficacy, emotional regulation in parenting, and parent-child relationship quality, frequently exceeding or augmenting changes reported for comparison methods when used concurrently. There was limited evidence suggesting corresponding improvements in child outcomes, and these were typically based on clinician and parent reports rather than systematic child-focused measures. The review highlighted substantial methodological limitations, including very small and homogeneous samples, lack of control groups, inconsistent standardized measures, and minimal long-term follow-up, underscoring the need for larger controlled trials to clarify whether EMDR therapy offers distinct advantages over other parenting-focused interventions. Rivest-Beauregard and colleagues' 2025 Mixed Method Systematic Review synthesized quantitative and qualitative findings on remotely delivered psychological interventions for adults with PTSD, acute stress disorder, and adjustment disorder. They focused on user satisfaction with online programs, mobile apps, video conferencing, and message-based treatments. Most of these interventions were CBT-based, with some using EMDR, mindfulness, or acceptance and commitment therapy delivered over 3 to 25 weeks. Across 74 studies and 27 interventions, self-directed modules had poor retention, whereas clinician-guided formats, including EMDR therapy delivered via video, showed better feasibility and completion rates. Participants generally reported moderate to high satisfaction. Participants emphasized the therapeutic alliance, flexible access, and EMDR therapy's acceptability when adequate support mitigated exposure-related distress. Identified barriers for other methods included technical problems, limited human contact, simplistic content, and privacy concerns. The review noted non-English and non-French studies were excluded, with a predominance of veteran samples and omission of prolonged grief disorder. The authors recommended expanding remote interventions, including EMDR therapy and other modalities beyond PTSD to adjustment disorders and other underrepresented diagnoses. Warren and colleagues reviewed randomized clinical trials of cognitive processing therapy, prolonged exposure, and EMDR therapy for adult PTSD to evaluate inclusion and reporting of sexual and gender minoritized participants. Across 5,011 records, 519 trials met inclusion criteria. However, only 10 trials, about 2%, reported any sexual orientation or gender identity data and enrolled at least one sexual or gender minoritized participant. 12.1% of 1,092 participants identified as sexual minoritized and 2.2% as gender minoritized. EMDR therapy, like cognitive processing therapy and prolonged exposure, was rarely examined for differential efficacy by sexual or gender minority status, and no trial explicitly tested whether EMDR therapy yielded distinct PTSD outcomes compared to these other first-line treatments in these populations. Inconsistent and incomplete encoding of sexual orientation and gender identity contributed to high risk of bias in half of the trials that included sexual and gender minoritized participants, limiting conclusions about whether EMDR therapy or other first-line interventions require minority affirmative adaptations or offer equivalent benefits. We will return to this topic shortly when we cover Ashley Austin's clinical instruction article on EMDR therapy for transgender and non-binary clients. So we turn now to Ashley Austin, who published a clinical instruction article in the Journal of EMDR Practice and Research, an article grounded in the adaptive information processing model that provides an affirmative framework to guide EMDR therapy adaptations for transgender and non-binary clients. Ashley Austin highlighted identity-based trauma from systemic invalidation, relational rejection, and gender dysphoria as central contributors to PTSD and complex trauma. She outlined how EMDR's 8 phases could be modified to address these experiences. Her main finding was that gender affirmation needed to be treated as foundational to safety, affect regulation, and a therapeutic alliance. She emphasized the need for extended preparation and resourcing that focused on identity-affirming experiences, nurturing and protective figures, and glimmers of gender affirmation and gender euphoria installed as adaptive memory networks. Secondary guidance described how history-taking benefits from explicit exploration and validation of chronic identity-based trauma, how desensitization requires affirming interweaves, dual awareness anchored in present-day authenticity, and space for grief. The installation and body scan phases need dysphoria-sensitive, choice-based, somatic work, centering affirming body regions and relational anchors. Closure and reevaluation are enhanced by normalizing incremental progress and tracking increased access to affirmation, euphoria, and self-worth as key indicators of change. Austin noted some limitations, as this framework remains conceptual. It relies on illustrative vignettes, an assumed dual competence in EMDR therapy and affirmative practice, and underscored the need for empirical validation, evaluation, and integrated training. She proposes that EMDR therapy holds a particular promise for transgender and non-binary clients when it explicitly centers gender affirmation, relational safety, and structural context to support both trauma resolution and a more empowered, affirming sense of self. Many in the international EMDR community were disappointed, but perhaps not surprised, when the American Psychological Association published their 2025 updated Clinical Practice Guideline for the treatment of post-traumatic stress disorder in adults. Once again, APA categorized EMDR therapy as a second-line treatment, despite EMDR therapy receiving a recommended or strongly recommended rating in all the other major PTSD treatment guidelines. An international team of EMDR scholars, including Chris Lee in Australia, Adi Jung in the Netherlands, Derek Farrell and Sharif Alithi in the UK, and Larissa Meisner and Sarah Dominguez in Australia, writing in the Journal of EMDR Practice and Research, published a narrative critique in June 2026. Their critique was based on a careful review and methodological appraisal of the existing PTSD treatment guidelines and meta-analyses. They compared the 2025 American Psychological Association PTSD guideline with 5 other recent national and international clinical practice guidelines and key meta-analyses using the AmStar-2 critical appraisal tool to rate review quality and examining population intervention comparison outcome time criteria, time windows for included trials, and handling of follow-up effects. In their analysis, they incorporated selected randomized controlled trials of EMDR therapy, network meta-analyses on PTSD and comorbidity, and implementation data from cross-cultural and humanitarian applications of EMDR therapy. In short, theirs was a thorough and contemporary analysis. They identified 5 sets of major issues. First was the scope of the review. The APA 2025 guideline relied on a small number of pre-existing systematic reviews and meta-analyses with vague selection criteria. There was no listing of excluded reviews and a very narrow PTSD population definition. In 2018, the Agency for Healthcare Research and Quality's amended their criteria to include PTSD studies where 80% of participants met full diagnostic criteria, and up to 20% of the rest could meet partial criteria for PTSD. However, APA only included studies in which 100% of the participants met the criteria for PTSD, while all other international treatment guidelines included all studies designed to assess the efficacy of a treatment for PTSD. The second issue was outdated research. The 2025 guidelines primary psychological treatment review only covered studies up to 2017, which meant multiple high-quality EMDR trials and newer, broader network meta-analyses available to 2021 were omitted, rendering the 2025 guideline effectively out of date at publication. Third was the quality of the selected reviews. The key reviews the APA guideline used for EMDR evidence had low or critically low AmStar 2 ratings, whereas higher quality reviews such as Unitri and co-authors' 2023 network meta-analyses, which found EMDR among the most effective therapies with low risk of bias, would likely have supported stronger conclusions. Fourth was the lack of transparency and inconsistencies in the decision-making process. The panel's PTSD guideline grid lacked predefined rules for translating effect sizes into strength of evidence ratings. They recorded comments about adverse events, maintenance of gains, comorbidity, and cultural acceptability that conflicted with the available broader empirical literature. Fifth was inadequate responses to the guideline public consultation. The guideline development process showed little responsiveness to substantial methodological critiques, both from panel members and external experts, repeating many problems already highlighted after the 2017 guideline and reinforcing concerns that lessons from earlier controversies had not been incorporated. In summary, these EMDR scholars' main finding was that the American Psychological Association 2025 guideline treated EMDR therapy as a second-line treatment, despite meta-analytic evidence showing effect sizes and long-term outcomes equivalent to those for trauma-focused cognitive behavioral therapy and cognitive processing therapy, including loss of diagnosis rates and benefits for comorbid depression and anxiety. The EMDR scholars acknowledged their critique was based on existing reviews and documents and carried possible allegiance effects given their professional ties to EMDR therapy, and that they could not fully disentangle historical and institutional biases within the American Psychological Association. In comparison to 5 other major clinical practice guidelines, the authors described the APA 2025 guideline as an outlier. They concluded that the APA PTSD guideline in 2025 underestimated EMDR therapy and diverged from international consensus. They stated that it should be revised using up-to-date, comprehensive, and transparently synthesized evidence with balanced expert representation across PTSD treatments. Listeners may want to compare the APA guideline with the major PTSD treatment guidelines, such as the World Health Organization's guideline, the US VA DoD guideline, the Australian guideline, the UK's NICE guideline, the International Society for Traumatic Stress Studies guideline, and the Cochrane guideline, all of which can be found in the reference list. That's it for today's episode of EMDR, the Science Behind the Therapy, from Sonoma Psychotherapy Training Institute. I hope this podcast helps deepen your understanding of the clinical science behind EMDR therapy. All the articles covered in episode 13 of the podcast can be found at somapti.com/blog in the August 2026 listings. If you enjoyed this podcast, I invite you to support the podcast by following, rating, or sharing it with fellow therapists. For information on our unique EMDR therapy training program, visit somapti.com. And for free articles on EMDR therapy, visit the resources section on andrewleeds.net. Thanks for listening. We'll see you next time.